Yesterday we have discussed everything about anatomy, musculatures, acetabulum, labrum, various ligaments around the hip joint, capsule, synovial membrane, movements of the hip joint, all we have discussed. So today's we will discuss about various surgical approaches around the hip joint. As hip joint is very important part of our body, and it connects our axial skeletal to the peripheral skeleton, so it is very important for you guys also. There are four basic approaches. There are four basic approach through which we can assess the hip joint and do various surgeries. So one is through the anterior part, which is called anterior approach and also called Smith-Peterson approach. Second is anterolateral, which is also called Watson-Jones approach. Third one is lateral approach, and fourth one is posterior approach, and fifth one is medial approach. So we will discuss all approaches one by one. First of all, anterior approach. Anterior approach, it gives safe access to the hip joint and ilium. It is also called Smith-Peterson approach. Indication for this approach are open reduction of the congenital dislocation of the hip, synovial biopsies, intra-articular fusion, total hip replacement, hemiarthroplasty, excision of the tumor around the hip, and pelvic osteotomy, which we do in pediatric age group in the congenital dysplasia of the hip. So these are the indication for anterior approach or Smith-Peterson approach. This is the position. We keep the patient in supine position and keep a bolster or a small bag underneath the ipsilateral hip. Long incision, as you can see, is marked starting from the iliac crest and to the anterosuperior iliac spine, and the vertical limb extend beyond the anterosuperior iliac spine. The superficial internervous plane lies between sartorius medially and tensor fasciolata laterally. Sartorius is innervated by femoral nerve, and tensor fasciolata is innervated by a superior gluteal nerve. Deep plane lies between rectus femoris and gluteus medius. Rectus femoris is supplied by femoral nerve, and gluteus medius is supplied by superior gluteal nerve. So superficial dissection, first we externally rotate the leg and stretch the sartorius, and we develop a gap, carefully cut the deep fascia through the gap between sartorius and tensor fasciolata. The structure here is which is very important is lateral cutaneous nerve of thigh. We have to be very careful about, because lateral cutaneous nerve of thigh lies just beneath the deep fascia, and we should be very careful about it. Sartorius should be retracted medially and tensor fasciolata down and laterally. Detach the tensor fasciolata from the iliac crest origin, and downward there is ascending branch of lateral circumflex artery. So we have to ligate it, otherwise it will bleed profusely and it will hamper our vision of the surgical field. So it is very important structure, ascending branch of the lateral circumflex femoral artery. Deep dissection, after separating the tensor fasciolata and sartorius, the deep plane lies between the gluteus medius and rectus femoris. Rectus femoris will retract medially and gluteus medius on the lateral aspect. The iliopsoas which we retract medially and pass a retractor over the superior part of the acetabulum. Now gently adduct and external rotate the limb, so our capsule get tightened up and we can easily identify it, and we can make a longitudinal incision or a T-shape incision in the capsule. Dangers in this approach: the neural structures which we can damage are lateral circumflex, lateral femoral cutaneous nerve, which we have already discussed, and femoral nerve which lies medially, so we should be careful about femoral nerve also. Vessels are ascending branch of lateral circumflex femoral artery. Extensile measures: this approach we can extend it proximally as well as distally. Distally we can open up the whole thigh through this approach, and proximally we can go up to the posterior part also, and we can access the iliac fossa also. So we can use this approach and extend it to further assess if in pelvic tumors or excision of the tumor, or in pelvic osteotomy. Second one is enterolateral approach, which is also called Watson-Jones approach. It is most commonly used for total hip replacement, and indication for this approach are THR, total hip replacement, open reduction for the fracture neck of femur, partial hip replacement या hemiarthroplasty, synovial biopsy, and other rare indication is biopsy femoral nerve. Again, position in this approach also supine position. Flex the leg up to 30 degree, adduct it, so your leg, the operating limb lies across the opposite knee, and tilt the table a bit away, drape the patient. Landmarks here are anterosuperior iliac spine, greater trochanter, femoral shaft, and vastus lateralis ridge. Superficial dissection: after skin incision, cut the subcutaneous tissue and reach the fascia or the posterior margin of the greater trochanter, and incise fascia lata, and there is then you enter the bursa or the trochanter. Divide the fibers of the fascia lata proximally and anteriorly in the direction of ASIS, and also distally to expose the vastus lateralis muscle. Lift the anterior flap and detach the few fibers of gluteus medius and develop a plane between tensor fascia lata and gluteus medius muscle. So this is your gluteus medius muscle, and this upper portion is tensor fascia lata. A series of vessels come across the plane, so needs to be ligated. The gluteus medius ligated retract posteriorly, and tensor fascia lata retract anteriorly. Now externally rotate the limb to stretch the capsule. You can incise the capsule in whatever manner you want. It can be either T-type or a vertical incision. Deep dissection, you need to detach abductor mechanism or and dissecting the femoral neck superficial to the capsule until a retractor can be placed over the anterior lip of the acetabulum. Two techniques for good exposure of the labrum: one is neutralizing the abductor mechanism and allowing the femur to fall posteriorly, and trochanteric osteotomy obviously you can do. So this is after vision after the trochanteric osteotomy. This portion is osteotomized greater trochanter. This is your whole of the acetabulum. You can see completely 360 degree acetabulum in this approach, and this is part of the femoral neck and femur. Dangers in this approach are: most common danger is femoral nerve, and because of the stretch neuropraxia can happen, so you should be careful about that. And you can enlarge this approach proximally and distally. Proximally, facial atta can be detached from the iliac crest, and distally you can expose the whole of the femur and approach the femur proximally, approach the proximal part of the femur. Now third one is lateral approach. Lateral approach, position of the patient, you can do it in supine position, you can do it in the lateral position, depend on the indication for which you are doing the surgery. So it is very excellent approach for hip replacement, and no need for trochanteric osteotomy. We can do the early mobilization of patient as gluteus medius is preserved, but not extensive as the enterolateral approach. It is a limited approach. Position, supine position, GT should be at the edge of the table. So this is the diagram, and internal nervous plane line lies again in the between gluteus medius and vastus lateralis. Superficial dissection, deep dissection split the gluteus medius starting in the middle of the GT. You should be careful that you should not go beyond 3 cm up to proximal to the GT, because there is superior gluteal nerve is lying there, and you can damage if you go 3 cm proximal to the trochanter. So you should be very careful. Split the fibers of vastus lateralis at the base of the greater trochanter, develop a muscle flap consisting of gluteus medius, gluteus minimus and vastus lateralis. Detach muscles from the greater trochanter and continue dissection anteriorly along the femoral neck till the anterior capsule of the hip joint exposed. Dangers here again, if you go more proximally 3 cm beyond the trochanter, then you can damage superior gluteal nerve. So you should be better to prevent it and make a tie a suture just 3 cm proximal to the greater trochanter, so you can not extend that proximally. You can also damage femoral nerve, and while retracting it gets stressed and neuropraxia can happen, so you should be very careful about it. The last one is posterior approach. We also called it Moore's approach. It is most commonly used for the total hip replacement surgery, acetabular surgeries, hemiarthroplasty, and it is very useful approach. Position for this approach is lateral position. Landmarks: greater trochanter, anterosuperior iliac spine and vastus lateralis ridge. Make a curved incision 10 to 15 cm in length. Begin proximally 6 to 8 cm posterior superior to the greater trochanter and continue to greater trochanter, and curves the incision in the line of the GT. Superficial dissection, it cut the tensor fascial atta and expose the vastus lateralis muscle and superiorly split the fibers of the gluteus maximus. Deep dissection, after splitting the fibers of gluteus maximus, we retract gluteus medius superiorly, and then the short external rotators comes in front of you. You should internally rotate, and you can cut short external rotators like piriformis, obturator internus, two gemelli. Detach all these short external rotators from the posterior aspect of the trochanter and incise the hip joint capsule, and you are into the joint. Here neural dangers are, you can damage sciatic nerve, which is just posterior to the obturator internus muscle, coming from the greater sciatic notch, and behind it traverse anterior to the piriformis muscle and posterior to the obturator internus muscle. Other nerve you can damage is inferior gluteal nerve and artery. Last and less commonly used approach is medial approach, and also called Ludlow approach. Usually we use this approach in the pediatric age group, especially congenital dislocation of hip or any abscess or septic arthritis of the hip joint, for the drainage of the septic hip. Position, supine position, hip should be flexed and abducted and externally rotated. Sole of the foot is lying along the medial side of the opposite knee. Landmarks here are adductor longus muscle. You can trace it from its origin to the pubic tubercle. Incision, longitudinal incision on the medial thigh starting 3 cm. Superficial dissection between adductor longus and gracilis. Deep dissection between adductor brevis and magnus till the lesser trochanter. Dangers in this approach are anterior division of obturator nerve, which lies at the top of the obturator externus, and posterior division of the obturator nerve, which lies in the obturator also. Enlarging this approach, usually it is minimal invasive approach, and we cannot enlarge it further, so we can use it for the only for congenital dislocation of hip or septic arthritis, only for a small incision and minimal invasive procedure only. So these all we have discussed, all 5 approaches: anterior approach, lateral approach, enterolateral approach, posterior approach and medial approach. These all cover the approaches around the hip joint. If you have any doubt, any query, you can ask me, and this is all about approaches of the joint.